Hello, Dr. Dave. I'm RCGP Templates. As another AKT looms, I've done a video on looking at 20 AKT style questions for administrative, and then we're going to do the same again for statistics. As we go through, I'm going to see how I get. I haven't really revised for this. I'm just hoping off the top of my head, but we'll talk through this and talk through some relevant videos that I've already done that may be of use. So let's hop over to this. This is on the RCGP sort of self-test bit. And what I've got on here is topic specific. And then let's go down to, let's find some stats. And then let's do it that way. I've probably gone past it already. Let's have a look where you are. Evidence-based medicine. So let's start the test. Standardized mortality ratio. According to evidence, injecting drug use of a standing SMR 10 times that of the general population. What's the SMU for the IDU group? Select one option only. Well, that is mean. Okay, they're probably going to chuck standardized mortality. So we're looking at a ratio, 10 times that of the general population. So it's then looking at that and think off the back of that it will be 100. It's either going to be that or 1,000. Nope, got that wrong. SMR is ratio of the observed number of deaths multiplied by 100. An SMR of 100 means that the number of deaths is the same would be SMR of 100 implies correct answer is 1,000. Okay, blast. So what's going to take a stab at that one? Attending and educate a new drug is being presented, which is the license for hypertension. The following results have been made. Dementia rate in the control group 4 and 10. Dementia rate, so it's the absolute, so numbers needed to treat. Right, fine, can do this one. So it is the absolute rate reduction. So 4 and, where have you gone, Mr. Calculator? Here you are. So it'd be 0.04 minus 0.02, which is equal to 0.02, and then it's the inverse of that. So 1 divided by 0.02, which is equal to 50. So the absolute risk reduction is 50, and thankfully it's there. We take a quiet breath. Yeah, there we go. I've got a video about this. That's how come I knew how to do it. I'll leave a link to it below and also sort of flag it up as we go. God, this is exhausting. I'm only 2 questions in. Come on, Dave. Keep going. Right. Oh, bloody hell. Following table shows positive likelihood ratios and confidence intervals of common presenting features for esophagogastric cancer. Blech, try saying that. Based on the above information, which present is the most predictive of esophageal cancer? Protect one interval. So we need the one with the highest likelihood ratio. So nausea, vomiting, bloating. And then we've got weight loss there as well with a very wide confidence interval, so it doesn't even overlap with that. So I'm going to go with weight loss. Go on, please be right. Oh, thank heavens for that. You see, a 64-year-old discussed recent blood test. He has a fasting cholesterol of 5.6. You decide to start him on new cholesterol-lowering medication, Redcol. The drug company claims that it can reduce fasting cholesterol by 25% in 6 months. Assuming the drug comes, what do you expect his fasting cholesterol to be in 6 months' time? Okay, so I would argue basic maths from this one. We want 25% off that. So 50% would be 2.8, half that again, that's 1.4, so 5.6 minus 1.4 would be 4.2. So let's see if it's there, and hopefully my maths done on the back of it will be okay. Good work, Dave. Right, happy with that. Next question. So you can see with these, even though they're medical, it's what I would argue is fairly basic maths. You receive a letter from a consultant at a local hospital describing a new study that she's organised in a fertility clinic. That's nice. We're investigating the relationship between mobile phone use and male infertility. A group of men referred to my clinic with no sperm will be questioned about their mobile phone habits. A group of aged, matched, related patients without sperm, referred to as a separate clinic, will also be questioned about their mobile phone habits using identical objective structured questionnaire. What's the single best description of the study type? Right, fine. So we've got 2 groups using retrospective data. So we are looking, I'm going to say, Oh, okay, right, fine. It's not that, because I don't know what it is. It's not a crossover study because you're not doing an intervention and then handing them over. It's not a randomized control trial because you're doing retrospective data. And I can't remember off the top of my head if it's a case control or a cohort study. I want to say cohort, you're getting... let's have a look. Cohort is risk, relative risk, whereas with control you're getting odds. So it's cohort study. Again, got a video on this. I should have watched this before sitting this exam because old Dave would have told new Dave what to do. No! I bet it's case control. Watch my video, you would have found out. Okay. The Department of Primary Care at the local university wishes to investigate whether the use of proton pump inhibitors increases the risk of osteoporosis. What's the single highest quality study to use? Okay, so this is, do you know, ignore the actual question because you want to know what's the highest quality study to use there. Okay, so out of this, the highest quality is meta-analysis. So actually, out of, if that's the pure question, my concern is whether actually looking at that, if you're doing university, for a university to do it, they probably want to look at something like a crossover. But again, strictly speaking, the answer should be meta-analysis. Oh, for heaven's sake, I am failing this today. To generate a false positive. I have not got a clue. I guessed at that one. I'll talk you through my reasoning. So, ultrasonography in diagnosis of gallstones. If it's a radiological image, then you can see it, and so you're going to get the feedback from it. Cancer tests, again, could be. So I would, when I'm looking at this, is sort of thinking about most likely to generate a false positive. It's going to be some form of blood test is what I instantly go to. So the ultrasound, the echo, I would instantly know they're fairly diagnostic, and also think about in practice, they're the ones that we do already from that way. Urinary beta-HCG, done gynae, and actually know that it's a fairly low threshold that beta-HCG is, so actually that's really useful, which leads your ANA in rheumatoid arthritis or the cancer antigen 19-9. Now, again, this is sort of a bit of a clinical guesswork, I would argue, because I've seen loads of patients who have got positive ANA and they don't do anything with it. So you're like, oh, thanks for that. So that's hence why I chose that. Right, jump into conclusions and then looking for facts to corroborate them. Which of the following types of bias does the above bit? So this is, I want to say it's confirmation bias, because you are looking for courtesy bias, don't know what that is. Congruence bias, don't know what that is. Publication bias, that's processing, giving one set of information, either positive or negative. And then outcome bias, let's see if I'm wrong. So it's either confirmation or outcome. I want to say that it's confirmation because you're jumping to your conclusion. You want to try and confirm it. So hopefully I'm not wrong on this one. There you go. Lovely. Right. So let's have a look at this. So numbers needed to treat. Research group was looking at management of moderate hypertension, divides its subjects into group 2. Group A with 1,700. Why are you being awkward? Receives antihypertensives. Group B with 1,800 subjects receives a placebo. After 5 years, the risk of stroke in Group A is 12%, whilst in Group B it's 20%. Right, fine. So we can ignore the numbers. We can look at the risk. So what we're looking at is the numbers needed to treat is the inverse of the absolute risk reduction. So all we need is the difference between the two. So 20%, 12% difference is 8. 1 divided by 8 because we need the inverse for this. So let's get my calculator out because I don't particularly want to guess today. Wait, what have I done wrong? I know what I've done wrong. Right. So 20% is actually 0.2. There we go. So reconvert it back into decimal. 12 then is 0. Oh, right. Nope. 0.12. 0.08. So we do 1 divided by 12. 12.5. Round it up as it's 0.5. Is there 13 there? Yes, there is. Check. Oh, thank heavens for that. This is stressful. Like, good luck if you're doing this. Assuming the normal distribution of data, lovely. Gaussian distribution. Which one of the following p-values would indicate a statistically significant difference between the trial and the control interventions? Ooh. Right. So we need p-value of greater than. Select one option only. So we need, assuming the which one of p-values would indicate a statistically significant difference between trial and control intervention, select one option only. So, right, so standard scientific we go for a 95% confidence interval, or 0.95. Do the inverse for the confidence intervals. That's where this 0.05 here. I think these are all red herrings, so ignore them. So I would sort of look at one of these two. Greater than, nope, insignificant difference. Less than 0.05, significant difference. Happy days. Again, got a video about confidence intervals as well from that way. Study design has looked at whether people have a right at night have an increased risk of cardiovascular disease. Patients aged 40 to 50 years will be followed over a 10-year period of cardiovascular outpours. So what type of study for? So you're going forward with this. Crumbs. So this is, so it's not a systematic review, it's not a randomized control trial, it's definitely not a meta-analysis, it's either cohort and it's not a crossover trial. We followed over a 10-year period and cardiovascular outcomes measured. If it was a crossover trial, you'd be looking at, they've worked at night and then they do a day shift, so you're altering your risk point from that point. So I'm going to hazard a guess that it's a cohort study. Again, got video on that. Please watch it. I wish I had. So, which one of the following best describes the ability to test correctly identify patients with disease? Which one of these following tests? Patients specify directly patients with the disease. Right, okay. Blast, I know what you're hinting at. It's either, so not talking about, it's either sensitivity or specificity from that point, and with the absolute risk that's talking about the intervention, so can you reduce the risk from it? Odds ratio, again, you've got two cohorts, a exposing factor, what's your risk of that? Negative predictive value, so how good is a negative test? So then your specificity, it's either your specificity or sensitivity, and I want to say it's your sensitivity. Oh, it's spin. No, I did get it right. Phew. There we go. Sensitivity is the ability to test correctly those with a condition, i.e. true positives. Yep. Marvellous. Right, come on, we're nearly there, Dave. Choose from the drop-down list one of the research methods that is the single most likely to prove the answer that you require. Each option may be used once, more than once, or not at all. That's nice. So, you found a marked drop in uptake to primary immunisation in your practice population over the last year and wonder what the most likely explanations are and how best to address these problems. Case study. Right, okay. So qualitative study, I think it's that, only because qualitative, you're not looking at, you're basically, it's talking information, it's talking data, so variable could be anything. So that's why I sort of pick it. Your pharmacy advisor advocating the use of particular proton pump inhibitor because of potential cost savings, but you have concerns about its clinical efficacy compared to your current first line. So actually, you want to cohort, so let's go with that one. Patient UC asks you if the condition could be linked to exposure to excessive amounts of smoked fish in childhood. So you're looking at retrospective data. And I want to say it'll be that one. So let's check. Blast! Right, okay. So I got the last one right. It's not a cohort study. What do you want? Double-blind randomized controlled trial. Oh, for heaven's sake. Okay. Fair enough. Yeah, so you're comparing two. That would make perfect sense. They've gone for a super high deal. I think I was swayed by the previous question where I got it wrong. But anyway. Right, statistics bias. Awesome. Which term describes the situation where survival will appear to be better in cases detected by screening without there being or necessarily being a real difference between the survival of screened and unscreened population? That is... Which term describes the situation where survival will appear to be better in cases detected by screening without there necessarily being a real difference between the survival of screened and unscreened population? Is it lead time rather than selection? It's one of those two. It's not not publication bias. The reason why I'm tempted with lead time bias is that lead time, as far as I understand, is where you have a period of time sort of set forward. So if you pick someone up early versus when you pick them up later, that it doesn't make a big difference, and that's why I'm sort of going with it. Go on. Please be right. It's either that or selection bias. I apologise. Yes. Yep. So lead time bias is apparent in cases of survival due to health conditions. So this is where sort of like there's no actual difference or no sort of benefit of detecting it early. You're asked by your primary care organisation to present the pros and cons of screening for a malignant condition that is prevalent in the locality. Which one of the following statements would be desirable in your screening programme? Wilson-Younger criteria, ladies and gents. Let's go. I wish I knew them off the top of my head. I'm sure with some editorial magic I'll add it on here. So which one of the following statements would be desirable in screening your population? So high sensitivity, so it's going to really pick out all the patients with it. Cost is irrelevant in providing. Clear my choice. Improving screening should always take priority over improving treatment. Nope. What again? The statement doesn't scan, and also the always in there. The test should have a low specificity. Treatment should ideally be carried out late in the natural history of condition. Nope. So we really want quite a sensitive test so that we're not that we're getting a lot of people sort of identified from it. Cost, nope. Right, let's see if we go here. Please be right. Off the back of our previous questions. Thank you very much. Okay, as if by magic. Wilson-Younger criteria, okay, to show the validity of this. So again, don't need to do some editorial magic. So this is sort of picking up that we're not, when you're screening, that you're actually getting people that you want rather than just the whole random population from that way. Power of statistical studies determined. Oh, that's mean. Why are you getting me to do power calculations? Right. Okay. I do know this. Because it's to do with your type 1 and type 2 errors. So it is, I want to say it's either that one or that one there. So 1 minus the type 1 error or the 1 minus the 2. I might be wrong on this one. Blast. Got that wrong. 1 minus type 2 error. Again, got a video on it. Should have watched it before doing this. Apologies, gentlemen, ladies, whoever's revising for their AKT. Whenever evaluating the effectiveness of screening, how does lead time bias affect morbidity and mortality? Right, okay, so lead time bias. So this was actually in relating to previous question. So it really has no effect on. It will have no effect on mortality because basically you're going to, regardless of when you pick up a condition, you're still going to treat it at the sort of the same rate. I'm going to guess at this one. Hopefully my logic is either that or morbidity. Yeah, there we go. Phew. Below is a forest plot. Oh, yes. Thank you. Forest plot comparing the outcomes of primary rehab versus on hospital admissions. What's the single most appropriate interpretation of these results? Let's see if we can zoom in. Right, there we go. So we've got, let's orientate ourselves from the bottom. Line of no effect. overall studies. So overall studies show favours experimental and favours control. So favours experimental. So whatever they're doing, so in this case, the pulmonary rehab shows that overall out of these studies, it's working. Anything that crosses this line, don't care about. So for it already, without going any further, Murphy, don't care about. These other two then show a significant difference. So let's talk about this. Which single and most appropriate interpretation is correct? Both Mann and Benkel studies show significant benefit. So that's Mann and Benkel study. Yes, that's correct. Each study shows significant benefit. Wrong. We've already talked through this. Murphy's doesn't. Murphy's study shows significant benefit. No, it does not. No study shows significant benefit. We know by the diamond that is not true. Only Benkel's study shows significant benefit. So I should have just stopped at the beginning. Let's zoom out again and see if I got it right. Wonderful. And if you're this far in the video and you're finding this useful, please, please, please drop a subscribe. It'd be really helpful. Share this amongst your friends, anyone doing their AKT. And show how badly I'm doing this. So, screening test must satisfy criteria. Again, more on the Wilson-Unger. For any given test, which of the following criteria would make it unsuitable to use as a screening tool? The test has a low negative predictive value. Now I'm going to clear my choice. Benefits of screening outweigh the risks of screening. Well, that's clearly, we want that to happen. The treatment in the early stages of the disease is proven to be beneficial. We want that. So again, wrong. Test has a high positive predictive value. So that means that a positive predictive value is basically if you've got a positive test result that there's a high probability that you've got the disease. So we want that. Yes, please. The disease is an important health problem. Yes. So it has a low negative predictive value. That is incorrect. We want a high negative predictive value because that goes on the counter. So there's a high reason that if you've got a negative test that you haven't got the disease. So we definitely want that. See if I'm right. Marvellous. Happy, happy days. Next question. Maybe worth a separate video because we've had two Wilson-Unger ones. Referral rates vary widely between GPs. Shock. With respect to urgent referrals for suspected cancer, which of the following statements is true? Lower urgent referral rates have a higher conversion rate. Haven't got a clue what you mean. Higher urgent referral rates have a lower conversion rate. Urgent referral rates makes no significant difference to cancer mortality rate. Lower urgent rates referral rates result in lower cancer mortality. Higher urgent referral rates result in lower cancer mortality. So I'm assuming, with respect to urgent referrals for cancer, so I'm assuming using the 2-week wait rule, which of the following bits? So I would argue that the more you're referring under the 2-week wait, the lower the mortality would be because you're picking up these cancers. That's my logic. It's a weird question. Yay! Good. Finish. Phew. Let's see what I got. What do you reckon? 60%? 75, maybe? Go on. Oh, your score, 78%. Okay, I'll take that. Peer score of 75. Phew. Right, fine. So, bit of a laugh. But more importantly, just hopefully give you an idea of sort of what videos are out there that I've done that should hopefully help you with your AKT revision. Again, one of my big tips is you've got to limit how much time you're going to deliver on your stats. If you look at previous AKT feedback reports, you're only getting about 50% of people who have actually, who are getting, so out of the 20 AKT stats questions, out of the cohort, they're answering about 10, 11 of those correctly. So even though I flunked a load of these, it's actually much better than the previous AKT feedback reports. I hope you found that useful. I'm going to shove a whole load of links to useful videos if you're struggling with your stats for it. Very, very best of luck for this. Check out my other 20% series that goes into a lot of this. Dr. Dave Highmarsh, GP Templates. Very best luck for your AKT.